Okay, great. And the changer? Okay, well, I will get started while awaiting the changer. So thank you very much for the invitation to be here. And as I understood my job from Ram, it was to say that air pollution has adverse health effects. Perhaps I should say that's true and quit, and we could move on to the next presentation. But in any case, I'm going to go on a little bit to the underlying information from epidemiological and other studies. In my third week of a position at the University of Colorado, having moved from Los Angeles, and as a reminder, Los Angeles does need to take credit for smog. It was first found there, and let's see. This is 1943, the first episode of ozone pollution in Los Angeles. At the time, the chemistry was unknown, and of course, Hagensmith at Caltech went on to identify that. Interestingly, at the time, this was thought to be a uniquely Californian phenomenon, now, of course, global. Now I've moved to Colorado, famous for its brown cloud, shown here. And then, of course, we are in the Vatican City and Rome, which is also not free from air pollution, a ubiquitous problem. This is 2015, when there were European-wide episodes. Now, as a point, air pollution, of course, is everywhere. We breathe in air pollutants indoors and outdoors throughout our daily activity. What would be good now, I think, to wake us all up is to take one breath, and if you do that, and it was about 1 liter or 1.5 liters, you just breathed in 1 million particles, even within this clean air. So our lungs are elegantly built to defend against this, but think about this. 10,000 liters of air a day, millions and millions of particles, some toxic, perhaps some benign. And in the end, of course, it's not surprising that the disease results. Systemic disease, like heart disease, results because these particles translocate, because materials come off them and enter the blood and are metabolized, reach the heart and other organs. So there are myriad health effects to be anticipated. I just want to tour us quickly around the world. We've done that already, but with some pictures just to make us think about air pollution. So here's Los Angeles, much cleaned up. We still exceed the US standards and certainly the WHO standards for air quality. Here, London and Paris, not free from notable episodes of air pollution, even in recent years. This picture I took out my hotel room in Delhi about 8 years ago, a pollution episode so notable it reached the front pages of the newspapers. And the question that I would raise here, and that we'll come back to, is could the kinds of acute episodes of air pollution that occurred decades ago that are well charted occur now? Are they occurring now? So something to keep in mind. So there is October 31st, pollution well above standards. Beijing, I'm sure many of you have seen these scenes in Beijing and other cities in China, picture taken by a friend quite recently. I've had some contact with the Women's Tennis Association, concerned about exercising vigorously in scenes like this, which is indoors where particles have penetrated. You've seen a map like this already. Most of the world living above the WHO guideline. But I think what is important, and I want to emphasize here, is that there is an inequitable distribution of exposure. So to the right, the proportion of people, the distributions of pollution exposures in China, India, and some other countries, a high-end, high exposures, and to the left, the United States and other countries. So we do have an issue of distributional equity of what people are exposed to and what the associated health risks are. So what are the health risks of air pollution? Many will start this story with the air pollution disasters of the 20th century. The London fog of '52, earlier Meuse Valley episode in the 30s in the United States, Sonora, Pennsylvania. If you haven't seen the London data, here they are. This is mortality during the week and subsequent to the fog, the levels of sulfur dioxide, and the level of smoke. Translate that into particles. The scale for particles is milligrams. The WHO standard annual 10 micrograms per cubic meter. Here we're talking about milligrams during the fog. You can see the deaths rise, and if you have sharp eyes, you'll see that mortality stays up afterwards, a delayed consequence. You don't need any advanced time series methods here to understand what is going on. And I think one concern that we need to keep in mind around air quality management is with the peaks that we are seeing in some of the megacities, could this happen again? Could it be happening now and we're not picking it up? Another real possibility. And then, of course, the combination of temperature with air pollution in cities perhaps like Delhi, among others, would add a double stress for mortality. In the United States, there were episodes like this across the east coast of the United States with notable mortality counts, but of course far smaller than London. These episodes sparked research beginning in the UK in the 1950s, moving and spreading the methods to the United States with concerted looks at the hazards beginning in the 50s and 60s. And if we look at what was being done early on, relatively primitive surveys, health in less polluted versus more polluted communities, some very early time series studies, and the general question were what were the adverse health effects of air pollution? As time moved on, we began to do more sophisticated studies, and several stand out. The long-term studies, the Harvard Six Cities study, where 6 communities were enrolled into a roughly 20-year follow-up study that has shown us that higher levels of air pollution are associated with increased risk of death. An important study done at my former department in Southern California, the Children's Health Study, tracking the health of children in multiple Southern California communities. And with these studies came a look at what people are actually exposed to. We began to put monitors on people to look at what happened in the real world. And some of the findings were notable. This is where we first began to understand the tremendous contribution of indoor smoking, for example, to personal exposure, and to understand the complexities of the mixtures of air pollutants that people were exposed to. And these studies focused on the exposure response, those exposure response relationships underlying the global burden of disease estimates. And now we've moved on to newer approaches using time series methods to building very large cohorts from health records like the United States Medicare system, the Canadian census, and others. And probably most importantly from these studies, they continue to show adverse effects at levels that we see now. And then this effort that has come through in the last presentation and the prior as to what are the key sources, where do we need to turn our attention to reduce the health effects of air pollution. So this is the story, and there are so many studies that I'm not going to show you a single one, but sort of give you general impressions. The U.S. Environmental Protection Agency every 5 years reviews the massive database of new findings and puts together something called the Integrative Science Assessment and reaches causal conclusions. So this is ozone, a pollutant quite controversial at the moment in the U.S., where we know there are adverse effects on the short term. Perhaps a decade ago, while I was at Hopkins, we and others showed links to mortality as well, already mentioned. So causal effects of ozone on respiratory health are certain and likely a contribution to mortality. There are similar reviews for particles, And again, a huge range of short-term and long-term adverse effects. And just to summarize a few of them here, short-term effects on the lungs, likely to be causal, effects on cancer, where, of course, IARC, WHO, has now concluded that air pollution is a cause of lung cancer. And then additional short-term and long-term effects that we'll review. I chaired the working group at the International Agency for Research on Cancer that concluded with these two conclusions. Air pollution and particulate matter are group 1 carcinogens. The dilemma from the point of view of control is that there's likely no threshold level. These are carcinogens that are most certainly operating without threshold on a probably more or less linear relationship. So here is the dilemma. What is the acceptable level of risk associated with cancer, for cancer associated with air pollution? Many would probably say 0, but of course not achievable in our society. So what are the risks at current levels? Well, for mortality, we continue to observe short-term increases. We have the longer-term increases of a number of specific causes of death that contribute to that burden of disease that has already been discussed. For morbidity, many adverse respiratory effects, for example, exacerbation of asthma in children, well documented, the cardiovascular consequences, reproductive effects, and then a great deal of concern about what are the susceptible groups. And as we look at susceptibility across the population, it seems that there are many groups likely to be at risk. This is a recent paper in the New England Journal of Medicine involving approximately 54 million people across our Medicare system that serves people above 65. Bottom line in this paper that came from the Harvard group is that statistically significant associations were observed at levels well below the current allowable standard long-term in the US and below the WHO standard as well. And then emerging risks. This is from Science Magazine, January. Teams from my former department and others at USC and other groups around the world have been actively investigating whether air pollution could have adverse effects on the brain. There's underlying work on the ways, the routes that particles could take to enter the brain, or components of particulate matter, and looks at so-called accelerated brain aging, something none of us want, Alzheimer's and other conditions. So there's a variety of effects being looked at. You already heard about reproductive outcomes, neuropsychological development. Studies have addressed autism, the work on brain aging, welfare effects, mood. There are now 3 or 4 epidemiological studies on air pollution and suicide, for example. And perhaps some of this is quite exploratory, but there are a range of additional effects under investigation at this point. We've already heard about the disease burden, and I'm not going to go through all these numbers again. The total is large when one adds in ozone, ambient air pollution, and household air pollution. And again, I think I'll just reiterate my comment earlier that we need to think about the difference between attributable, which is based on a counterfactual that we would like to get to. In fact, it's for these estimates well below the WHO standard, and what can be avoided and what can be avoided in different contexts. So perhaps some good news that evidence-based, science-based air quality regulation can work. And I'll turn just quickly to the US experience. Our Clean Air Act, passed in 1970, has a strong public health mandate for the administrator of the EPA to set a standard based on criteria, evidence, and allowing an adequate margin of safety requisite to protect the public health. So this standard has guided us with our 6 major outdoor air pollutants. Even as vehicle miles in the economy have grown, emissions have dropped. And if we take a look at the national ambient air quality standards, you can see that for all of the major pollutants, there's a more or less continued decline in recent years. Pollutants declining at different rates, but our science-based approach has worked by and large to drive down levels to where they are now, putting aside the question of what will happen in the future. And we've been able to observe benefits of these reductions. And again, this speaks to the need to show that, yes, air quality regulation does benefit public health. These two papers come from the team at the University of Southern California that are doing the children's health study. The paper on the left in the New England Journal of Medicine is about better lung growth in children who grew up under cleaner air quality conditions in Southern California. So they made comparisons of successive groups of children over about a 20-year period over which air pollution improved. And they were able to show that the lungs grew more for those children who came later. And the technical details, I am just skipping through. The paper in the Journal of the American Medical Association, same study, same idea, and now there are less respiratory symptoms in relationship to air pollution for those children in the later cohorts who experienced cleaner air as they were growing up. So we're able to say with this kind of work to policymakers that yes, public health benefits when air quality is improved. So this is direct evidence that such will happen. Now, I think just in terms of closing out the discussion, the dilemma of air quality regulation with some pollutants, some health effects for which there will be no risk-free level, air pollution and lung cancer, for example, how do we determine what a standard should be? And I'll just give you some of my thinking about this. If we reduce from where things actually are, and this goes back to attributable and avoidable, we may be able to get to the target, but not down to the point that is lowest, the so-called residual, where we are back to background. So in thinking about sort of the policy futures and how we drive air quality regulation, we have to think about what benefits can be achieved and how those benefits relate to sort of the maximum that might be achieved under the sometimes impossible situation of going down to background levels. And this speaks to this difference between avoidable and attributable. I will point out that the WHO air quality guidelines in 2005, I was part of that group and now the group looking at new standards, we faced that dilemma. We knew that the air quality guideline for particles, for example, of 10 was simply out of sight for many countries, and that's why there are the tiers within the WHO guidelines. And I think as we look to this next set of guidelines, again, we will have to look at a useful set of guidelines for different scenarios. The work is not so far along, but I think those same principles may prevail. Now, since I'm from the United States, it's hard not to comment on our current environmental situation. This is a paper I published with two colleagues who I'll tell you about in March in the New England Journal of Medicine. Tom Burke was the head of research and development in the Obama administration, and Bernie Goldstein was the head of research and development in the Reagan administration. So we span two interesting eras. You may also have perhaps forgotten that it was during the Nixon administration that the Clean Air Act was signed, that it was so important in the United States. So we are facing an interesting time. I hope it's a fleeting one where evidence is not so much on the table as it should be in terms of driving the air quality standard. And just to leave you with one sentence from this piece, scientific evidence does not change when the administration changes. Thank you.